So, respected President, respected Secretary Madam of SAMS Maharashtra, our beloved members, GC members, all the national dignitaries, GC members from national who have joined, and are all members from Karad ISA as well as SAMS Maharashtra. A very good evening to everyone. Today is a very special day for me personally. It gives me immense happiness, pride, and a deep sense of responsibility to welcome you all to this academic webinar organized by ISA Karad in association with SAMS Maharashtra. This is the first webinar of ISA Karad during my tenure as secretary, and I cannot express in words how grateful I am for the trust you have all placed in me. This position is not just a designation for me, it's an opportunity to serve, contribute, and grow together with this wonderful academic family. And special thanks to SAMS Maharashtra. ISA Karad has always been more than just an organization. It's a family where seniors guide us, peers support us, and juniors look up to us. My sincere aim during this webinar is to make it academically vibrant and make our body professionally strong and emotionally connected. I'm thankful to SAMS Maharashtra. We are fortunate to have with us today two highly respected and accomplished speakers who will be sharing their knowledge and experiences. I'm confident that today's sessions will not only add to our academic growth, but it will also help us inspire in our daily clinical practice. On a personal note, I want to thank each of all of you, and without dealing further, I warmly welcome all of you from the bottom of my heart. Now, before we begin this webinar, in the spirit of growth and responsibility, I'm happy to share that ISA Karad has recently procured Dantrolene ampoules, and it is a very important step, and especially for management in this era. In a short while, Dr. Shraddha Naik ma'am, who is a GC member SAMS from Karad, will be sharing complete details regarding this initiative with all of you. So over to you, Dr. Shraddha ma'am, to share the details.
Good evening, everyone. Good evening, respected President of SAMS, Honorable Secretary Madam, Honorable Secretary of SAMS, Dr. Sachin Sir, SAMS Newsletter Editor, Dr. Shilpa Ma'am, our National GC, Parul Ma'am, all the office bearers of SAMS, ISA National, all the President Secretaries and GC members of all the constituent branches of SAMS present here, our esteemed speakers for the day, and all my fellow ISIans. I know you all are eagerly waiting to hear from our speakers today, and so are they just as eager to share their knowledge and experience with you. However, I would just like to take a couple of minutes to announce this thing, which is like really something important because I was working on it since my tenure as the president of ISA Karad, but now which has finally become a reality. And I'm pleased to share on this August platform of SAMS that ISA Karad is now equipped with Dantrolene. This is how it looks like. Oh, if you can see. And this was made possible mainly because of the process that was made super easy, effortless, transparent, and flawless by our immediate past president, Dr. Bala Venkat sir, our past secretary, Dr. Bajwa sir, president ISA National, Dr. Naveen Malhotra sir. And it's through their guidance and support that we were able to procure this ampule of Dantrolene quite seamlessly from Perrine Healthcare. I have to mention especially Dr. Manjiri Deshpande, madam, who's the president of ISA Solapur, with whom I was in contact all the while regarding the paperwork and the procedure, and she's guided me all through. Dr. Neha Panse, madam, who's Honorable Secretary ISA Pune, who first instilled in me that we also should look forward to get Dantrolene, and Dr. Manisha Katikar, madam, again, our esteemed GC member and from Solapur, and all these three were pioneers in guiding me as to how to procure one. Our SOPs regarding Dantrolene are also ready, but I do not wish to take the valuable time of this webinar discussing them. However, I'm truly happy that as far as malignant hyperthermia care is concerned, the safety of our ISA Karad member is now well taken care of. And I sincerely want to thank all the members of ISA Karad who for their wholehearted support in this venture, because without their encouragement, approval, and of course financial contribution, this wouldn't have been possible. So if any further details are required to any of you on this topic, feel free to contact me at any time on my personal number or via WhatsApp. Thank you so much, everyone, for your precious time. Over to you, Samrat.
Thank you, madam. Thank you for updating us with that knowledge. And I would now like to invite our respected dignitaries, respected President Sir, Dr. Avinash Musle Sir, President SAMS Maharashtra, to just add a few words and guide. I would now like. Am I audible right now?
Yes, you
Yes.
are.
Now you are audible.
Yes.
So I now request respected Dr. Avinash Bhosle sir, President SAMS Maharashtra, to kindly guide us and let us know
I will not
about
take
his
much
views.
much time of this webinar. You can start it. But as you declared that Dandrolin is available, first I congratulate all the office bearers and members of Karad ISA for making a difficult looking task of procurement of Dandrolin in the Karad, the smallest branch, and the smaller city like Karad. So I special congratulate to Shraddha and those who had taken special pain for making it possible. And
Thank you,
also
sir.
I
Thank you
congratulate
so much.
and I wish you all the best to the
लॉकर
new
मेडा
team.
छमने
Yeah, new team of ISA Karad for their future endeavors. Thank you very much.
Thank you, sir.
Over
Thank
to
you.
over to Samrat.
Thank you, sir. Thank you for the kind words. I now request respected Secretary SAMS Maharashtra, Dr. Sheetal Dalal ma'am, to kindly express her views and words. Ma'am, you are muted, ma'am. You can unmute yourself, ma'am. Your mic is muted.
Hello,
We can hear you now.
hello.
We can hear you,
I
ma'am.
must
We can hear you.
congratulate the
Yes, you are doing.
President, Secretary, and the GC member and all the ISA member of Karad brand for great efforts in procurement of Dantrolene. Really hats off, a great round of applause to all of you. And best of luck to this year. And congratulations to the new team, Secretary and President. And best of luck to the new team for upcoming venture. Whatever they have decided, they will be succeed with the bank. Thank you.
Thank you, madam. Thank you. Thank you for your kind words. I now request Karne sir to kindly, if he's available to. Sir, are you? We are not able to hear you, sir. You are muted.
Good evening
Yes,
to all.
I'm available. I'm here. Hello. Hello.
Vikas Karne sir, you are audible.
Okay. Good evening to everyone. Dr. Shraddha, yeah, I'm sure you have taken a lot of pains to procure the Dandrolene, and I think it's a much needed thing. And congratulations to the previous team and also the current team for this effort and having Dandrolene and making our patients in Karad and around the Karad safe, irrespective to the malignant hypothermia. And I would encourage you to pass on the experience to all the city branches across Maharashtra and outside also, so that your experience will encourage all our city branches to procure it. And I wish you're muted, Shraddha.
Thank you, sir. Thank you so much. I'm happy to help anybody who is getting inspired and wishing to procure this. I think it's the need of the day, and all the branches should procure at least one vial of Dantrolene.
Absolutely,
So
absolutely.
I'm
So
always
good
happy to
going.
help
Yes,
anytime.
we know that. Good going and keep it up. You can share your experience on our GC group also, so that the
Sure.
discussion at the other city branches will also get initiated.
Surely, sir.
And I wish you all the best for today's webinar. I think over to you, Samrat. Thank you.
Thank you, sir. Thank you. I now request respected Dr. Shilpa Tivaskar ma'am, SAM's newsletter editor, to just
Yeah,
comment
I'll
about
just
this.
say one line, Samrat, because I think we are already late. Congratulations, Shraddha Madam, Team Karad, Kanse Madam, Samrat, Jayvant Sir, everyone. Congratulations once again. Yeah, over to you.
Thank you. Thank you.
Thank you,
Jayvant
madam.
sir, would you like to say something? President Karad ISA, Dr. Jayvant Patil sir. Sir, you are muted. You are muted, sir. You are muted.
Patil sir, you are on mute.
Respected President Sir, SAMS Dr. Avinash Bhosle Sir, Honorary Secretary Sheetal Ma'am, Honorary Vice President Dr. Vikas Karne Sir, Editor-in-Chief, SAM's newsletter, Dr. Shilpa Tivaskar ma'am, esteemed speakers of today's webinar, Dr. Vinit sir and Dr. Bindya ma'am, participants of all webinar this. Good evening all. I, Dr. Jayavant Patil, President ISA Karad branch. It is my privilege to welcome you all to today's webinar. We are grateful to our distinguished speakers and state leaderships for their presence and support here. Regarding webinar, it is highly relevant in today's clinical practice. Extremes of age present unique physiological challenges requiring meticulous assessment, tailored drug dosing, vigilant monitoring, and gentle perioperative care. As there are key differences about cardiac output, drug metabolism, thermoregulation, CNS responses, etc. So the webinar theme is of great sense. I am confident that the session will be academically enriching one. Thank you.
Thank you, sir. Thank you. So, Shraddha ma'am, would you like to add anything, or we'll proceed with the main webinar
No.
right now?
No, I guess we'll proceed because it's already late. The speakers are waiting and the audience is also waiting to hear from them. I can share the details personally if anybody wants to procure Dantrolene, not an issue.
Yes, I just want to mention and inform that we have had one conference at Mahabaleshwar in 2002. Like this, the topic was like this only, but we given the name innocent and experienced at that time for geriatric and pediatric patient. Okay, thank you.
Great. Thank you, sir. Thank you. To proceed with the webinar per se, the moderators for today's webinar are respected Dr. Nasima Kanse ma'am and respected Dr. Jayavant Patil sir. So let me introduce the moderators of today's session. So, respected Dr. Kanse ma'am, it gives me an immense pride and heartfelt joy to introduce her. And Dr. Kanse ma'am is serving as professor and head Department of Anesthesiology at Krishna Vishwavidyapit, Karad. She is not only an excellent academician, but she is also a highly experienced clinician. And she is a true mentor who has shaped many careers and countless students with her wisdom, patience, and dedication. Ma'am holds a very special place in the journey of Karad ISA. She is the founder secretary of Karad ISA and has also served as our past president of Karad ISA and governing council member for SAMS from Karad ISA. The strong roots which Karad ISA stands today are laid by visionaries like her. She is also a postgraduate guide to students. She is a very excellent speaker and has delivered talks at national and regional levels and state levels. And she is always a guide for all her students. And ma'am, your presence with us today is not just an honor, it's an inspiration. And Karad ISA will always remember and be grateful for you, for your leadership, your guidance, and unwavering support. I welcome you, ma'am.
Thank you so much, Samrat. Thank you for the introduction.
Yeah. So the next speaker, the next moderator for today's talk is respected Dr. Jayavant Patil sir. Sir is currently the president of Karad ISA. He is ex-consultant Department of Anesthesiology from KIMS Karad. He is also ex-senior resident emergency.
Hello.
David Karad. Sir is a country hospital.
I think we lost you in just a short while ago. Your net connection, something.
One second. So I was introducing Dr. Jayavant. Is ex-consultant Department of Anesthesiologist at Civil Hospital Karad and director and head of Department Anesthesiology at Karad Multispecialty Hospital Karad. And he's also freelancer anesthesiologist with a vast experience and a good academician also. Currently is the president of Karad ISA. I welcome you, Jayavant Patil sir, to moderate this session. The first talk for our webinar today is by Dr. Vinit Bedekar sir. And I request Dr. Nasima Kanse ma'am, who is the moderator for the session, to introduce Dr. Vinit Bedekar sir. Let me just share his CV on the screen. Is it visible right now?
Yes.
Yes,
Dr.
I
Vinit?
can
Yes, it is.
see. Yes, I can see it. Dr. Vinit
Screen
Bedekar sir
share
is a
Samrat होता.
huh? Dr. Vinit Bedekar sir, he is a full-time senior consultant, neonatal and pediatric anesthesia. He is attached to Department of Pediatric Anesthesia, BJ Wadia Hospital for Children, Parel, Mumbai. He has been executive committee member, ISA Mumbai Metro Branch. He has done his FNB and fellowship in pediatric anesthesia at BJ Wadia Hospital. He has done 2 years of fellowship in pediatric anesthesia also, and presented numerous papers and posters at the state and national and international conferences. He has organized a hands-on workshop on focus in pediatric patients, and he's also co-authored 9 publications in national and international anesthesia journals in pediatric anesthesiology, including original studies and 2 chapters in pediatric anesthesia textbook. Say, his areas of interest are safety and teaching in pediatric anesthesia, pediatric regional anesthesia, pediatric vascular access and focus. On behalf of Department of Anesthesia and ISA Karar City Branch, we welcome you here. And you can start, I think you can start with your lecture.
Thank you, ma'am, for your kind introduction. Thanks a lot. Can I share the screen?
Yeah. We had a student at Wadia, Dr. Vikrant.
Yeah, he is. We all know him very
He
well.
also completed his
He
fellowship.
was a very good student. Yes, ma'am.
Yeah.
Is my screen visible?
No, your screen is not visible.
Sorry.
Yes, it's visible now.
Okay. Is it visible now in full screen?
Yes.
Yes, yes.
Yes.
All right. So good evening, all. A big thank you to the organizing team for this wonderful opportunity. I'm here to simplify pediatric anesthesia. The aim of my talk is to try and simplify the everyday glitches that we commonly encounter in our pediatric anesthesiology practice. We also would like to delve into the challenges faced during the perioperative patient care, especially when it comes to pediatric patient, and let's see how to handle them with utmost care. Well, before we begin, am I audible? Hello?
Yes, you are.
Yes, sir,
Yes,
you
you
are
All right.
audible.
Okay. Before we begin, I have to state that I have no conflict of interests. All consents for the clips which you would be seeing later on have been taken, and I do not receive any funding for this. Greetings from one of Maharashtra's biggest and busiest tertiary care pediatric hospital, BJ Wadia Hospital for Children, Mumbai. We at the Department of Pediatric Anesthesiology offer 10 institutional fellowship seats and 2 FNB seats in pediatric anesthesia every year. Well, this was back in the day. This was in the beginning of 2000s. A lot has evolved since then. We see more and more anesthesiologists who are getting trained in subspecialty anesthesia, and well, rightly so. The end result is an anesthesiologist with better knowledge, better competence, stronger clinical and judgmental skills in that area of selected subspecialty. When it comes to pediatric patients, this is what happens most of the times. I label it as the apprehension triad. What is the apprehension triad? It's basically while caring perioperatively for a child, it's stressful for everybody. We have an apprehensive patient, we have apprehensive parents or caregivers, and definitely an apprehensive anesthesiologist when an anesthesiologist is especially an occasional pediatric anesthesiologist. What are the apprehensions about? Well, the patient is scared of the hospital, the needles, and masked medics. The parents worry about the child's health, who has to undergo anesthesia and surgery. Frequently, we get asked questions like, will my child be okay? When will my child resume feeding? And when will my child wake up and whether the child will be in pain or no? As anesthesiologists, especially the occasional pediatric practicing anesthesiologist, the questions start from, do I really accept the case? Well, if I accept the case, how do I manage the kid? What will my plan of anesthesia be? And definitely, what if I land up into a laryngospasm or any postoperative complication? Well, regardless, these are the mandates. Firstly, as we all know, do no harm. Do not extrapolate adult data into pediatric. Children are different. Do not they are not miniature adults. Do not force forcefully hold a child and just do a spinal just because you are well versed with it. What might be a wonderfully managed case for you might just be a nightmare for that awake poor little child with so much mental trauma. Always treat pain. So as we go through the lecture, we'll walk through the perioperative management of the childs in the slides to follow. It all starts with building a rapport. How do we build a rapport with a child? It's not only building a rapport with a child, but also to know the parents or the caregivers. So it's a multidisciplinary team effort. It's a continuous perioperative process. Well, talk to the parents of the child, know the child through the parents' eye view. And if the child is more than 6 months, the child is definitely playful and interactive. Be comforting and caring. Don't just go and rush into explaining the anesthesia modalities, especially for patients who don't know what anesthesia is. It might just scare them. Well, firstly, how would you approach a child? Always be well groomed, be well dressed, be caring, and be confident. Always remember that the child can perceive your vibrations of the body and your thought. So it helps a nice, pleasing, caring, confident attitude or approach will help calm a child and the caregivers, and also inculcates a certain level of confidence in the parents. It all starts with a thorough pre-operative evaluation. As we all know, we see the history, the demographics, do a general physical exam, look, listen, feel, do a systemic exam. Especially when it comes to pediatric patients, look at the dorsum of the hands, look at the venous access sites, whether the veins are really visible, or are we dealing with a patient with a difficult venous access or a chubby child. If you are planning for a block, an upper limb, lower limb block, or a caudal block, look at the skin over the block site in the preoperative area. Does it have any discoloration? Does it have any dimples? Or does it have any infection at the site of the block to be performed? After that, what you do is you see the investigations, give the NBM orders, and inform risk consent. It's as simple as this, doesn't it? But then, of course, there are the nitty-gritties of pediatric anesthesia, which plays a role. Now, these are tough cases in pediatric anesthesia. These are the preterm baby of 24 to 36 weeks of age, extremely low birth weight children of less than 1 kg, patients with GDD or global developmental delay and failure to thrive, NICU graduates, and patients with congenital anomalies. Be extra careful while handling such patients. Always try to seek expert help in such situations. Now, the slides ahead, each slide is like a lecture topic in pediatric anesthesia. I have tried to simplify this and give the gist of each of the topics or the subtopics when it comes to managing a child well, for the purpose of better understanding. My motto or my goal here is whoever are listening to me should be able to do at least the basic ASA1, ASA2 basic cases, daycare cases in pediatric anesthesia with good confidence. So always seek help of an expert when it comes to tough cases. Well, let's gear up for the frequents. We all have encountered these problems and are still continuing to encounter these problems. The commonly faced problems when it comes to a pediatric patient is a child posted for surgery who either has a URTI or an LRTI, a child with fever, or the child with anemia. So I have grossly divided in the slides to come these things into red flag signs and the green flag signs. So basically, when you encounter a specific situation, the green flag sign will tell you go ahead with the case. The red flag sign will tell you kindly evaluate or kindly treat before going ahead with the elective case. So now let's see respiratory tract infections and elective surgery. As anesthesiologists, we fear respiratory tract infections because, of course, increased risk of airway complications, the most dreaded laryngospasm, as we all know. So what are the red flag signs associated with respiratory tract infections? They are a respiratory tract infection patient with a fever, which is more than 38.5 degrees Celsius, associated with nasal discharge or productive cough, with some different sounds on auscultation like wheeze or crepitations, and in general, a systemically unwell child. Be very careful while assessing these patients. If it's an elective surgery, you may rather defer these cases and elect to be for the case to be treated before taking up the case. Fever and elective surgery, if the fever is low grade without any other associated symptoms, you might just as well go ahead with the elective surgery. Red flag signs include fever, which is associated with recent onset rhinitis, pharyngitis, or otitis, a patient who's dehydrated and has fever, and a patient who has an impending illness. You might defer this elective procedure and treat the cause of the fever. Well, anemia and elective surgery. Many a times in many setups as well as nursing home setups, especially when we get these hernia circumcisions, they usually have low hemoglobin. So anemia is multifactorial. You have to see the etiology and ask the history and just suggest which suggests the nature of why the anemia is there at the first place. Then look at the nature and urgency of the surgery. If the surgery is purely elective and if these red flag signs are present, like a surgery which is associated with significant blood loss, anemia which is associated with protein energy malnutrition, or anemia with a systemic disease, then hold on. Be very careful about taking up these procedures. If you ask me a rough figure or a rough estimate of a hemoglobin under which you should not accept a case, I would say 8. This is not a blanket statement. It is not a transfusion trigger. Transfusion trigger is something different, which is not in the scope of my lecture. But usually a hemoglobin of 8 gram per deciliter is required for doing an elective surgery in a pediatric patient. Well, airway. There are many signs of assessing a difficult airway in pediatrics as well. They are all difficult to kind of perform. What I would suggest is to go for these 3 basic signs. Look at the neck extension, look at the external features, and look at the extent of mouth opening. In a child who's not very kind of vocal or doesn't follow your commands, when the child cries is when you get the best oropharyngeal view. What are the red flag signs when it comes to airway? Any cases of retrognathia, micrognathia, that is small mandible or a receding mandible, microtia, that is small ear, and a ear tag, as seen in the figure, predicts that the larynx might be anterior. So be careful and plan your airway management accordingly in such cases. Well, investigations, I have seen at many places, people just ask for an array of investigations, almost everything that is present on that chart, just because it's a pediatric patient undergoing general anesthesia. It is absolutely not required. Ask investigations only if you suspect a pathology from your examination and from your history. You can ask for investigations to assess severity of an underlying gut lesion. For example, if you're dealing with a patient of CKD, you might ask for a BUN and creatinine extra investigation to assess how severe the disease is. As baseline, if it's going to alter the treatment. Well, nil by mouth, many guidelines and amendments to these guidelines have happened from time to time. Still, prolonged preoperative fasting is still common in children. It's either owing to a delay in the OT list because of the long OT lists, non-reliable caregivers whom you can't trust that he or she has given milk 4 hours prior to the procedure, or an anesthesia provider who's very apprehensive, and sometimes there is a general dictum that keep the patient's NBM for a longer period of time, we'll supplement with IV fluids, which is a very wrong dictum. So basically here what I want to say is, for all practical purposes, you can give plain water to a patient 1 hour prior to the surgery. So don't keep your patients fasting too much. It's not good for the patients as well as the intraoperative and postoperative course. You can definitely give plain water to these patients 1 hour prior to procedures. Patients who are on breast milk, you can give breast milk up to 4 hours prior to procedures, and formula milk and solids as 6 hours, as we all know. Well, the problem of inadequate fasting and semi-emergent procedures. For example, you go to a place where the procedure has to be done in a couple of hours, but the patient is not fasting. With POCUS nowadays, it has changed the name of the game. Ultrasound of the abdomen gives you an idea of something called as the at-risk stomach. So how do you define at-risk stomach on an ultrasound? It's gastric fluid volume of 1.25 ml per kg or more. If the patient is having that amount, then your patient is potentially at increased risk of pulmonary aspiration. So you plan your anesthesia and airway management skills accordingly. Well, we live in an era of easy and sometimes misleading information, and often deal with well-Googled parents. We all do that in private nursing homes, in corporate hospitals, or in teaching institutes. The concern over the anesthesia-related neurotoxicity, whether it is a myth of limited consequences or a threat of epic proportions. How do we deal with such situations? Well, since 2015, there were many trials and studies which were done, namely the MASK, the GAS, the PANDA study. And all these gave a dictum. What was the dictum? The dictum was a single brief anesthetic is likely to be safe. Neurotoxicity related to anesthesia is multifactorial in etiology, and there is no significant difference in IQ after a single anesthetic exposure. Here, I would like you all to remember the rule of 2. The rule of 2 when it comes to anesthesia related neurotoxicity defines the high-risk group of patients, or patients who are likely to get neurotoxicity after an anesthetic. They are patients less than 2 years of age, patients who undergo 2 or more than 2 exposures to anesthesia or general anesthesia with or without hemodynamic perturbations, and an anesthetic which is lasting for more than 2 hours. So rule of 2 helps us to kind of group these patients into high risk for neurotoxicity kind of patients. Well, all these things are done. When we start doing the case, I think this is a sweet spot of the entire events to follow. The niche which will define the fate of a case And in my opinion, it is a quintessential tool of pediatric anesthesia practice. Pre-medication, which is often looked down upon, is one of the most important steps in doing a perfect pediatric anesthesia practice. You pre-medicate the child well, everything is calm around you. The parents are calm, the caregivers are calm, and the anesthesiologist is calm as well. There are many drugs. There are many drugs which can be used as pre-medication. The most preferred one, or the most commonly used one in most places, and the drug perhaps I feel in my own practice has the least complications when it comes to pre-medication, is midazolam. The dose, as we all know, orally it can be given in a dose of 0.5 to 1 mg per kg 20 minutes prior to the procedure. Intranasally, it can be given 0.3 mg per kg 15 minutes prior to procedure. Well, you can, while giving orally, you can either consider it by mixing it in 25% dextrose or in paracetamol syrup. If you mix it with paracetamol syrup, it will give you a two-way benefit. It will pre-medicate your child and as well as give a preemptive analgesia. Intranasally, you can mix some Loxicard in a 1 cc syringe and gently put the drops in the nose of the patient. Always remember, appropriate monitoring and patient or caregiver education is important when it comes to a pre-medication. Always tell the patient's relatives or the parents that the patient is going to be drowsy after a while, and to support the neck of the child and not to let the child play. Just keep the child in the lap and support the neck throughout the period of pre-medication. Well, now induction. Induction can be done either inhalational or intravenous. A well pre-medicated child can accept a mask well, that is with a good mask acceptance score, and also sometimes allows a good IV cannulation. Well, this is a small video of a pre-medicated child who is pre-medicated with intranasal midazolam. And I want you to observe here in this video as we play how the staff is holding the child and supporting the neck, and how the IV is taken. It is always better to scan for the visible veins in the preoperative area if you're planning for an IV after pre-medication of a child. I'll play the video. So the cleaning of the dorsum of the hand will always give you an indication whether the child will really accept the IV or he or she will retaliate. In this case, we were successful in taking the IV. Well, in case a child is retaliating and if you're short of hands, you can do something called as a jugaad, which we most often do in any setups. It can be done in any setups like a nursing home practice or a corporate or a teaching hospital. You can use a mask as a harness if you're short of hands, induce the patient using sevoflurane, for example, and tie the mask while you take the IV. This is how you use a simple face mask or a cloth mask and tie it as a harness so that the patient is left breathing spontaneously over sevoflurane and you can access an IV easily. Always remember to cover the eyes so that we prevent any kind of corneal damage. So here the patient can be left breathing spontaneously and we can take IV in a good depth of anesthesia. Well, taking an IV, when we deal with patients who are difficult to cannulate, you can use these principles: local vasodilatation, as we all know, tapping or using a tourniquet or tapping over the vein, or local warming of the area causes vasodilatation and the veins are visible. The very commonly used apparatus these days is these near infrared devices, which are easily available, and they really have increased the first attempt success of IVs. The only problem with it sometimes for the novice people is depth perception, but with practice, it definitely becomes easy. Ultrasound, as we all know, can help in patients with difficult IV access. Airway management, this is kind of a, it's kind of a, in a nutshell, how to manage a pediatric airway in a nutshell. Of course, this practice might vary from places to places and with the experience of anesthesiologists. So I put it this way: surgeries which are surface surgeries, or they are non-cavity invading surgeries, you can use face mask as a harness. For example, you're doing a circumcision or you're doing a hernia, you can use a face mask, give a caudal or give a penile and a ring block. Most ophthalmic procedures can be done under supraglottic airway devices and spontaneous or controlled ventilation. cavity invading procedures and laparoscopic surgeries, the gold standard is definitely endotracheal intubation. Again, as I said, many places can have different kind of approach to these airway management strategies, but this is what is generally followed and generally safe in pediatric anesthesia practice. Here, I would like to give you a small little finger trick. Now, look at my little finger here on the glottis of the patient. This little finger technique can be used in patients, especially who have anterior larynx, to give you the better glottic view. So what it does is the amount of pressure which is needed for you to just visualize the glottis and not to close the glottis is directly in the control of the person doing the laryngoscopy. Sometimes what we see is when another person is giving the glottic pressure, either the glottic pressure is not given properly or the pressure is so much that the glottis is closed per se. So this technique has helped me. It can help everybody of us in our everyday day-to-day practice. In a nutshell, in most cases, we use Ringer's lactate. It can be safely given in a dose of 10 to 20 ml per kg. Glucose can either be added in proven hypoglycemia cases or in high-risk groups. What is high-risk groups for adding glucose or high-risk group for hypoglycemia? We will see in the slide to come. Acute intraoperative correction of hypoglycemia, if you require, should be given with 10% dextrose in a dose of 2.5 ml per kilogram. Well, glycemic control, as we said, multifactorial. These are the high-risk groups in which glucose has to be supplemented in the intraoperative period. They are preterm babies, infants of diabetic mothers, patients on total parenteral nutrition, and known diabetic patients. Well, again, roughly, if I have to give you a figure, what to treat, 60 or less than 60 with or without symptoms, definitely go for correction of hypoglycemia. Usually with a baseline infusion in the intraoperative period, they don't land up into such hypoglycemic crisis. But if at all you see a figure of 60 milligram per deciliter, treat. OT temperature. Now, ideal case scenario with respect to OT temperature is in a full-term neonate, we would like to have the OT temperature of 27 degrees Celsius and a premature neonate at 29 degrees Celsius with a relative humidity of 40 to 60%. But in these cases, whenever you keep temperatures so high and the relative humidity so high, we also get a sweaty surgeon. Some surgeons are not okay with it. Hence, what we have to do is we have to kind of do away with the convection and evaporation part of it. So use plastic wraps or Gamgee wraps, use forced air warmers with the bear huggers as is shown in the figure, and try to maintain normothermia. Always remember, hypo as well as hyperthermia, both can be dangerous or deleterious to the patient care. Well, the most talked about, an array of regional blocks is also the dictum these days in pediatric anesthesia, and rightly so. The variety of blocks out of which are available, the most commonly out of which are used are the truncal blocks, especially the TAP blocks and the ilioinguinal iliohypogastric blocks, the brachial plexus blocks at its various levels, and the most versatile of it all is the caudal block. Caudal block can cover right from the thorax up to the lower limb. Well, I was requested by the organizers to talk and show a few things about ultrasound guided caudal. So here I have a couple of videos. I have attempted to show how do we go about scanning the epidural space or the caudal epidural space, and how we get into the epidural space using a triple technique. Triple technique is landmark technique plus peripheral nerve stimulation and the ultrasound confirmation. Now, this is a tad bit too much into regional anesthesia, but since I had a request, I said I will put it up so that everybody of us will understand how we do it. So this is how it all began, with the palpation of the PSIS and the sacral cornu, and hence today we are able to visualize what lies beneath. Now, the clip consists of our everyday palpation method, and then the three important views. Always remember these views as we go. I will also be explaining. Firstly, the transverse view at the sacral cornu, then the longitudinal view, and then the midline transverse view, which is beneficial as our local anesthetic enters the epidural space. I'll play the video and I'll explain as we go. So this is how we palpate the PSIS and the sacral cornua, as we all know, and the other way of palpation as well. Confirm the sacral cornua. Place your probe in transverse at the sacral cornua. What do you see? You see something called as the frog eye appearance. This is the frog eye appearance, and the nose of the frog is the sacrococcygeal ligament. In the longitudinal view at the sacrum, As we scan up and down, on the posterior part, the lower part, we can see the bones or the sacrum and hyperechoic lines. The most hyperechoic of them all is the sacrococcygeal ligament, as we'll see in the pictorial depiction. This. And then the midline transverse view. This is also called as the incision congruent view. Basically, what we have to see is the fall in the posterior dura. Now, here, SP is spinous process, PD is the posterior dura which falls, CE is the chorda equina or the spinal cord, and CSF. So what we expect at the incision congruent level is the fall of the dura. That means our drug is reaching the incision congruent space. Well, so let's try and give it more objectivity to it. Then as we advanced from the landmark technique to the PNS, what PNS did it gave more objectivity. That is, we went in, we stimulated the phylum terminal with a 4 to 5 milliampere current, and we saw an anal wink or a anal twitch, which disappeared at 2 milliampere current. We achieved this physiological confirmation, and the visual confirmation is seen by the needle in the caudal epidural space on sonography. So this is the triple technique which is used for doing a caudal block. So this is the landmark technique for insertion of the needle, which we will confirm on the sonography. There you go. And then we stimulate the phylum. We need to use a higher current, that is 4 to 5 milliampere, because the phylum branches are very thick. So here you can see the anal twitches which are not so very well noticed. So hence we adjust our needle depth so that our needle is placed right into the caudal epidural space, as we see on the sonography. And then we stimulate it again, and then we can see our PNS response has become better. So we start at a 5 milliampere current, and then we reduce it to 3, and gradually and slowly it will start disappearing. There. And then we see a midline transverse view, and there you go, the fall of the dura at the incision congruent space when you are delivering the drug into the caudal space. So this is how we do it. The triple technique, or these are all three techniques used to reach the caudal epidural space. Do we do it every day or no? Not really. What it adds is it adds objectivity, that is physiological confirmation, and a real-time sonography image. Well, this chart will definitely disappear if you do caudals using ultrasonography. This is something called as troubleshooting. As anesthesiologists, the logical troubleshooting is the name of the game. Here is a table. While doing a caudal block, if you encounter these problems like CSF aspiration, blood aspiration, bulge, a local anesthetic bulge at the sacrum, or resistance to injection, what do we do? When we do it sonography guided, this chart ideally should vanish. If we are not doing it sonography guided, if you get a CSF on the aspirate, abandon the procedure. If you get blood in the needle, withdraw the needle or introduce another needle so that there is no blood. Local anesthetic bulge means the tip is lying subcutaneous, reposition your needle. And if you have a resistance to your injection, you are not really in the space. So reposition your needle, and most likely you are in the subperiosteum. Well, pediatric spinal, I'm not saying no, but definitely a guided approach from my side. Why? My concerns are the thecal sac ends at a very lower level in children as compared to adults. So there is always a risk of higher injury. The higher CSF turnover makes the block height unpredictable, and it also wears off quite easily and quickly, and it does not give me a post-operative analgesia. And there is no clarity on diagnosis and management of post-dural puncture headache, especially when it comes to neonates. So, well, to be or not to be, you have to decide on your own. It's definitely not contraindicated, but I would definitely say it's guarded. I think most commonly it is used in patients who are ex-preterms on caffeine for apnea of prematurity, coming for example, a bilateral inguinal hernia. I would still prefer an awake caudal than a awake spinal. Well, post-operative pain management, definitely multimodal, as we all know, diclofenac suppositories, paracetamol, either syrup form, suppository form, or IV form. Multimodal analgesia is the way to go. Complications, most commonly encountered complications are laryngospasm, intraoperative emergence agitation, which can be very, very, very problematic or concerning to all, and post-operative nausea and vomiting, out of which laryngospasm, I feel, might land up the patients into morbidity. So what do we do in a nutshell? If you land up in a laryngospasm, give 100% oxygen, you call for help, you give CPAP, open up the laryngospasm notch, deepen the plane of anesthesia, and remember not to stimulate by any suctioning or any airway devices in lighter planes of anesthesia. You can safely use propofol to deepen the plane of anesthesia either during induction or after extubation. Well, little patients, gentle care, and happiness, that is really priceless. This is the aim. This is what we try to achieve every day: a happy patient and a happy anesthesiologist. This is the gist of it all. I would really be happy if I have managed to intrigue any kind of interest amongst anesthesiologists, especially the youths present here. You're most welcome to do observerships or fellowships at BJ Wadia Hospital for Children in Pediatric Anesthesia if you feel pediatric anesthesia is your calling. With a whole lot of passion to the subject, compassion, and gratitude, I hope I made sense towards safe pediatric anesthesia practice. Thank you so much.
Thank you, Dr. Vineet, sir. It was an excellent lecture, and I'm sure all my PG students have really benefited from this. Two questions for my PG students I would like to ask you.
Sure, ma'am.
Can I ask you two questions
Yes, ma'am.
before we proceed for the next lecture? This is for the PG students that if you want to give clear fluids, are you strictly following this clear fluids one up prior to surgery? Still, have you all started?
Yes, ma'am. We also sometimes what happens is in the afternoons, there are cases and the patients are really cranky. For example, today itself, we had a patient who was just crying because he has had his last meal yesterday at 9 p.m. So we even give clear fluids right before, like 15-20 minutes prior to taking the patient in. We can add some Glucon-D to it if you feel that the child is a bit drowsy. But water for sure, definitely, why not? And as we all know, pardon, ma'am?
Volume?
So volume, as I said, for example, if it's a 10 kg child, you can give half glass of water or something like that. It should not exceed like or if you have syringes, that would be the best. For example, you are giving a 1 ml per kg volume, take a 10 cc syringe, aspirate some water in 10 cc syringe, and let the child drink 10 cc of fluid.
And second question is regarding caudal.
Yes, ma'am.
Which formula you follow and how much you all give?
So now again, the Armitage formulas, the modified Armitage formulas, but as I said, ultrasound has changed with respect the formulas with respect to incision congruency. But in general, as a general dictum, circumcisions or anything related to surgeries towards the sacral level, you can use a volume of 0.5 to 0.75 ml per kg. You can also go up to 1 ml per kg in inguinal herniatomies. OPEXs and surgeries at a level of T10, you can use 1.25 ml per kg. And above that, people have gone up to 1.5 ml per kg. There are concerns with respect to increase in the intracerebral pressure, intrathecal pressure when we use higher volumes. Well, that is to be dealt with in depth with respect to pediatric regional anesthesia. With USG, what has happened is you can just, for example, you want a level of T10, and you are doing the caudal, you can take, for example, 1 ml per kg in a 10 kg child, and you can keep your USG probe at the level of T10 spinous process. And when you see the fall in dura at T10 spinous process, you stop injecting. Whether it's 8 ml, 9 ml, or 10 ml, it shouldn't matter. Your drug has reached and your drug will act. So this is what we follow in our practice.
Thank you so much. To you, Samrat. Over to you.
Thank you, sir. Vineet, sir, it was an excellent presentation, and I'm
Thank you
sure
so
that
much.
it has benefited all of us, including all the practitioners as well as the PG students. Excellent presentation, sir. So, with the permission of moderators, can we go on to the next talk?
Sure,
So
there are no questions as such. Only one question was there from
Yes, sir.
Madam, I think.
Yes. Questions in the chat box, ma'am. We can take it at the end also.
Sure, no problem.
Yeah. So I would now request respected Dr. Jayavant Padil sir, President Karad ISA, to introduce our next speaker, Dr. Bindya Salonke ma'am. I'll just share her CV. Over to you, sir, Jayant sir.
Yes. I take the opportunity to introduce our esteemed speaker, Dr. Bindya ma'am. She is a distinguished professor known for her exceptional academic excellence at the Department of Anesthesiology, Critical Care and Pain at Tata Memorial Hospital, Mumbai. With years of dedication to academics, she has been mentored to students and guiding force in our society. Her topic, Gray Matters, Anesthetic Challenges and Solutions in Geriatric Patients, will be definitely enlightened for all of us. Thank you, ma'am.
Thank you.
Hello.
Thank you. Thank you for the kind introduction. I'll share my
Over to you,
screen.
ma'am. Thank you.
Yes, ma'am, you can share your screen.
Visible?
Yeah, it is visible.
Yeah.
Yes.
Good evening. After such excellent talk by Dr. Vedika, let me go to the other extreme of the age, that is geriatric patient. So anesthesia consideration in geriatric population. Let's go how do we balance the physiological changes and the precise care in this patient. So outlines, we are going to see the physiological changes with the age and the anesthetic implications of it, preoperative assessment, intraoperative concerns, and postoperative consideration. Okay, how we go about with the care, the same we will go with this. So why is geriatric so important? Why are we talking so much about geriatric anesthesia? So it is a rapidly growing population now, you can see, because of the advance in the medicine or advance in the patient care. Now the age group of more than 65, which is being considered as a geriatric patient population, has been increasing rapidly. There is a high surgical and anesthetic burden in this population which you have seen. I don't have the Indian data, but in US, around 1/3 of the population. Someone talking something? Or should I continue?
No, I think there was some disturbance. Let me just, I request rest of the people to just mute their mics. Yeah, ma'am, you can continue.
Yeah. So the burden in US, it is said to be around 1/3 of the surgeries all are happening are for more than 65 years of age. So there is a reduced physiological reserve in this patient, high perioperative risk to all the anesthetic agents which have been used and all the anesthetic and overall, and there is a high incidence of cognitive complications in this patient. Complex pharmacology, they might be on the polypharmacy, so that needs to be taken care. They might be having multiple comorbidities, needs to be taken. Shift of goal care. From now, just leaving, we have to see that how they survive with the good quality of life. That is what we have to see, and need of specialized approach. So, as I said, aging is associated with the aging is associated with the progressive loss of physiological functional and functional this in the organ system. So it can be physiological changes in the aging, as you say, all basal metabolic rate, the muscle strength, the muscle mass, the mass of all the organs, everything decreases with the age. So physiological changes. Cardiovascular, so let's go as per the system. Cardiovascular changes. Age-related arterial thickening and stiffness is very commonly seen in the elderly patient, which will cause a reduce in the vascular compliance, which will cause an increase in the afterload. So the left ventricle has to pump against this increase afterload. So there will be left ventricular hypertrophy. Also, most of these patients are hypertensive with the age, so they also will have the left, because of that also there will be left ventricular hypertrophy. Also, we see, so in the today echo, when it is done, you might see the left ventricle function, good function, maybe 50 to 60% AF, but there might be a diastolic dysfunction, which has been seen around 50% of patients in more than 65 years of age. And now this diastolic dysfunction will add to the decrease in the preload, which is the sole which is needed for pushing the blood against this increased vascular increased afterload. So that is one of the things. Then there is also reduced sensitivity to the beta receptor. So because of this, the hypotension, if it is seen, especially at the induction of anesthesia, it will not be counteracted much better, like how it will be for the when there is the sensitivity of the beta adenosine receptor is not reduced. So, similarly, there is a baroreceptor response also has been seen to be decreased in this patient, and you can see the cardiac, the myocardium, conducting system, and the valves being atherosclerotic of fibrotic infiltration in this patient. So you will see more and more of arrhythmias in such patients. So also this patient have a sympathetic hyperactivity, which will lead to the increase in the vascular tone as well. So what are the clinical implications of all this, what we are telling about a cardiac? There is a preload. So this patient are preload dependent now because afterload is increased. Because of the stiffened ventricles and the diastolic dysfunction makes the elderly more dependent on the atrial kick. Atrial kick is the last contraction of the atria, which will cause the feeling of the ventricle to maintain the cardiac output. So arrhythmias or tachyarrhythmias or tachycardias or atrial fibrillation, which is most common in the pediatric, in the geriatric patient, you will see it will be very less better tolerated, and this patient can go in myocardial ischemia as well as a diastolic heart failure in this patient. Also, the hemodynamic instability, anesthetist can remove the baseline sympathetic tone and blunt the baroreceptor reflexes. So this will cause the unpredictable hypotension during the induction, and that hypotension will take time to overcome, like not like an adult patient. Also, when we are giving the anesthetic drugs, we have to be very careful of the dosing, because again, this dose, what you use for the adult may not be the same dose for this elderly gentleman, can cause a profound hypotension. Next comes the respiratory system. The lung loses its elasticity, and whereas the chest stiffness increases, chest wall stiffness, because of the collagens all have become elastic. Now the lung elasticity of the lung will increase, but as well as there is the osteoporosis, the stiffening of the joints, all this will cause like a cage of the chest. So as well as the diaphragm will get flattened in the elderly patient. All this will cause an increase in work of breathing. Also, closing capacity increases with the age, and it can exceed the FRC at the age of 65, even in the erect patient. We'll see that. And there is also blunting ventilatory response to the hypoxia and hypercarbia, which is very important to counteract hypoxia in this patient. So here you can see the schematic representations of the lung changes associated with the aging. If you see, there is not much change in tidal volume, but the vital capacity with the aging has decreased. FRC, yes, there is an increase, slight increase in FRC, but it is with the residual volume. Okay, the residual volume increases more. And in the right side diagram, if you can see the functional residual capacity in the upright at the different age group, and this is the functional in the supine position, whereas the closing capacity keeps increasing, and it increases more than functional residual capacity in supine position at around 45 years of age, and at around 65 even in the upright position. So this will cause the early collapse of the respiratory bronchioles, and that will lead to the atelectasis and shunting. So if you can imagine, like hysterectomy, robotic hysterectomy or laparoscopic hysterectomy is happening, where you give a tendon position, which will again cause an increased risk of atelectasis, flattening of the diaphragm. Along with this, with the age, if the closing capacity in the spine will overcome the FRC, then there will be more profound collapse, and we might have to give a little higher PIP, or we might have to recruit a little bit in between intermittently for this patient. So what are the clinical implications? Yes, difficult airway is one of the things. As you all know, elderly patient, loss of buccal fat, edentulous patient, they are difficult mass ventilation. Stiff joints will be there, decreased spinal mobility will be there. That will all cause a difficult intubation for this patient. Then there is a vacuum mismatch. The changes in the small airway will cause a collapse of the small airways, which will call atelectasis and shunting. So this patient are at high risk of atelectasis and hypoxia. Aspiration risk, because of the diminished laryngeal reflexes in the elderly patient, loss of the esophageal gastric sphincter tone, there is also the mobility of the esophagus is decreased, ciliary clearance by the airways decreased, cough response is decreased by the patient in the elderly. All this will put the patient to the increased risk of aspiration, and this will all together, atelectasis as well as the aspiration risk, will put the patient to the higher risk of postoperative pulmonary complication. Next, we'll come to the central nervous system. Progressive reduction in the brain mass, neural density, blood flow to the brain, and the neurotransmitter receptors has been seen in the elderly patient. In the peripheral, dural permeability will increase, and there will be spinal canal narrowing. There will be the foramen will get stenosis, and the narrowing of the spinal canal will be seen. So this and there will also be seen a decrease in the myelination of the nerve fibers. All this will cause the increased sensitivity of the older patient to the anesthetic agent. The MAC of the minimal alveolar concentration of the anesthetic agents which is required inhalation, that decreases approximately around 6% decrease with each decade after the age of 40. So we have to titrate our anesthetic agent in such a way that we don't cause a profound cardiac depression and hypotension in this patient. Cognitive complication, which is most commonly seen in the elderly patient. So this patient are prone to post-operative delirium and post-operative cognitive dysfunction, which is associated with the longer hospital stay and more comorbidity, more post-op morbidities and long-term or functional decline is seen. So why do we see this? So any surgical stress or stimulus, it will cause a neuroinflammatory mediator release. So now the blood-brain barrier is a kind of a dysfunctioning or not is more permeable in the elderly patient because of the endothelial dysfunction. This will cause this neurotransmitter to cross the blood-brain barrier, and that will cause a microglial activation in the brain, and this will cause further neuronal apoptosis as well as the central pro-inflammatory cytokine release. All this together leads to the cognitive complications in the elderly patient. Regional anesthesia sensitivity, because of the dural permeability has increased and that the spinal canal has been narrowed and there is stenosis of the foramens. Because of that, the duct dissipation is slower. So it remains in the spinal canal for the longer time. Because of this, we see the exaggerated effect of the neuroaxial blockade. Similarly, with the peripheral nerve block, which I have said already, the myelination has decreased. So the lesser dose of the drug also is adequate enough to cause the good block. Now with the ultrasound and the PNS guided, with the ultrasound guided block, we can see the deposition of the drug in the peripheral nerve block as well. And that helps us in knowing that this much drug is enough to cause the peripheral nerves in the solution. Next comes the hepatic and renal system. So renal blood flow, renal cortical mass, and GFR, everything decreases. Everything decreases in the elderly patient, and GFR decreases by 10% per decade after the age of 40. There is also blunting of the renin-angiotensin, aldosterone-angiotensin axis, and the hepatic mass also has been seen to be decreased in the elderly up to 40% at the age of 80. So along with this, there will be decrease in the blood flow to the liver as well as the enzyme activity. Also, you might see the albumin decrease because of the nutritional status may not be great. So we might see the decrease in albumin in this patient as well. But mind you, don't remember, take a blood serum creatinine and BUN in this patient as a marker of the GFR, because already the body mass, the muscle mass has decreased. Because of a decreased muscle mass, the creatine production also is decreased. So that will lead to the overall decrease in the creatinine level. So that won't be a good marker. So what are the clinical implications for all this is there will be delayed clearance of any anesthetic drugs which we are using, because this reduced organ function leads to the slower drug metabolism and excretion by the kidney. So this will cause the increase in the accumulation of the drug and can cause the toxicity. Also, like if you use morphine, which has a active metabolite, that is excreted by the kidney. If kidney function not good enough, that will also get accumulated and add on to the effect. Similarly, these patients are more vulnerable to the AKI, acute kidney injury, because of the similar issues, and that's why we have to avoid the nephrotoxic drugs. NSAID we have to be careful about, and IV contrast also we have to careful about. But one dose of it will not cause a we have to monitor this patient for the RFTs if we have to go ahead with a contrast or NSAID for this patient. Electrolyte imbalance, yes, there is a reduced response to the renin and aldosterone makes the patient susceptible to hyponatremia and hyperkalemia. So when you're doing a pre-op assessment, electrolyte is a must in the geriatric patient because hyponatremia may go unnoticed. There is also a decrease in the serum albumin level, which will cause an increase in the protein-bound drugs like fentanyl may increase in the concentration further in the central compartment. Metabolism and body composition. The changes, total body water and the muscle mass decreases and the body fat increases by 20 to 40%. So all of this will cause altered volume of distribution. So lipophilic drugs like propofol have a larger volume of distribution, slow release from the adipose tissue. This will prolong their effect. So what happens? There is a decrease in total body of water and the decrease in the body muscle mass. So all this will cause the central compartment volume to decrease. Because the central compartment volume is decreased, as soon as you give the anesthetic drug, the initial concentration will be very high for the drug. So we have to decrease the concentration of the IV anesthetic agent almost by 50% and should be graded whenever. Also, the increase in the body fat will cause an increased volume of distribution, which will be slowly released in case of lipid soluble drug, and that will prolong the action. Along with this, if there is a kidney and liver is also not functioning optimal, that will also cause the metabolism and elimination of this anesthetic drugs delay, and that will also cause the increase in the prolonged effect. So we have to be very mindful while with all our anesthetic drugs. Thermoregulation, yes, it's the most important thing. Because of the reduced muscle mass, shivering has been decreased. This will cause the impaired thermoregulatory control and makes the elderly high susceptible to the perioperative hypothermia. This hypothermia can further cause the coagulation abnormalities, and that can cause the cardiac ischemia as well. So keeping the patient warm, this elderly, because they have very thin skin, their muscle mass is low, they can and shivering mechanism not there, they can lose the vasodilation effect is very high with the inhalation and with our anesthetic agent. All this can cause the loss of heat very easily. So temperature monitoring is must in this patient, and like pediatric, the warming blankets along with the IV warmer should be used. The IV heating, the IV fluid should be used by the heated system for the elderly patient. Musculoskeletal scheme, the changes being the geriatric patient often suffer from the osteoporosis, degenerative joint diseases, and fragile thin skin. So this makes the IV securement, the IV access difficult. The IV skin slips. We have to just pull the skin well and take good care and in a single pick try to get the IV. Also positioning. Because of all this positioning, we have to be very careful. One thing, there is stiff joint and fragile skin. They are predisposed to the nerve injuries, fractures, and pressure ulcers. So padding of all the body prominences is must and to be taken care as a team. The surgeon, the technicians in the OT, and the anesthesiologist, it is their shared responsibility to give the good positioning and good padding for the patient. Also, because of osteoarthritis and spinal degeneration, the spinal and epidural anesthesia, it may be technically difficult. Okay, you may hit bone every time. So those are the difficulties which you may face. So, unique anesthesia challenges in elderly, which we have already kind of discussed, all the physiological changes in the respiratory, vascular, cardiovascular, drug response. Polypharmacy is one more challenge. So, these patients are mostly either having some chronic disease like COPD, then hypertension, diabetes, or IHD in the past. So they might be on multiple drugs. This polypharmacy can cause interaction with the anesthetic drugs as well as the interaction with each other. So we have to be careful. Cognitive vulnerability. So we have to be very mindful in pre-anesthetic checkup only. We have to see that this patient's functional decline is there or not, if the cognitive dysfunction is there or not, and that we have to rate and assesses post-operatively. Thermoregulation we have already spoken, and positioning and frailty also, which we have to see in this patient. So let's go to the pre-operative assessment. First thing is physiological and functional changes. All these changes in this different system, whatever we have spoken till now, this needs to be taken care of, and we have to see to that these components are being seen during the preoperative assessment. Airway has to be checked as usual for any difficult mask holding and everything. Any comorbidities should be jotted down well. If they are optimized or not needs to be taken care of. Polypharmacy, yes, if multiple drugs, if in blood thinners, we have to see to that when it to be stopped, if it can be stopped, or we have to continue and go ahead with a small, the less risk surgeries or not. Then frailty, cognitive disorder, these are the main important things. Only in elderly patient we have to see this. Nutritional assessment, like in any other patient, we have to go ahead with the nutritional assessment, anemia assessment for the patient, and if required, during the rehabilitation, nutrition, physiotherapy, all this needs to be optimized till the time we prepare the patient for surgery. And last is the decision-making capacity. So we have to see to that this patient is in the cognitive mind so much that he can understand what is the indication of this procedure we are undergoing. Okay, he can understand and communicate with the physician what are my pros and cons of going for the surgery, what are the possible complications I can face, and the patient should be able to take the decision, rational decision of to go for the surgery or not. There can be multiple patients who come for osteoarthritis. They say no, we don't want to undergo the surgery, and then we have to respect for that. It's not like so we have to give them the list, what are the risk factors, what can happen with you, and these are the things. And if they are in a sane mind to take the decision, it is their decision, they have to take it. If not, then there comes the legal representative, and in emergency surgery, it's a different ballgame. So we have to have a comprehensive geriatric assessment. So what it is a team-based approach where the anesthetist, surgeon, geriatrician, nutritionist, physiotherapist, and social worker all come as a group and work on this patient and patient's family. It is a multidimensional, multidisciplinary assessment of the medical condition, functional condition of the patient, cognitive, physiological, if there are any addictions to the patient, that needs to be seen, and social domain of the patient. The goal is for individualized perioperative plan to minimize the function, maximize the function, independence, and quality of life. The advantages of this comprehensive geriatric assessment is it predicts the postoperative complication, delirium, and mortality, which needs to be explained to the patient when patient comes for the surgery and the relatives. It reduces the postoperative delirium or cognitive dysfunction, independence risk. It improves the functional recovery and enables the rehabilitation and optimization. If there is anemia, if there is albumin is low, you can start giving the high protein diet to the patient. Anemia correction can be given. If the patient deconditioned, physiotherapy can be started. If patient is a smoker, cessation of smoking can be done. All this needs to be done. So for this cognitive comprehensive geriatric assessment, there is something called as TUG test, which is just time up and go, which can be done in any of our pre-anesthesia OPDs. So there is a patient is made to sit on the chair. 30 meters from the chair, there is a line drawn, and patient is made to get up from the chair without a support, walk till that line of which is 30 meters, turn back and come back and sit on the chair. If patient takes more than 20 seconds for this, then we have to go for a full comprehensive geriatric assessment for this patient. Otherwise, this patient is a lesser risk and can go ahead with the surgery without a comprehensive assessment. So what are the core components of this? One is medical and condition and frailty. So we have to see the comorbidities what patient has, either by the Charlson score, ACR, RS score, frailty assessment, vision and hearing impairment if there is there, that needs to be taken care of or addressed. Functional status of the patient, either the activity of the daily living or instrumental activities. Activity of daily livings are like the normal bathing, dressing a patient can do, or patient can do the instrumental, that is like patient can go for shopping, patient can manage the money, patient can travel. All this will be called as an instrumental. If that dependency is there, then we have to see that a strong predictor of complication is there in this. That means the functional status of this patient is not good and that the complication rates are high in this patient. Similarly, cognitive and psychological, we can do the mini-COG test, and if that comes positive, then we can go for a further assessment of the patient. Also, the nutritional assessment as a mini nutritional assessment or anemia screening, albumin. These are the small things which we need to see in a pre-anesthesia checkup as well. So we can send this patient either to the geriatric clinic if you have, or we can optimize the patient with a comprehensive treatment. Medical reviews. If the patient is on polypharmacy, more than 5 drugs patient is on, then this needs to be addressed, and it may be if some inappropriate medication this patient is on, that needs to be stopped. Like even the addiction, that needs to be stopped and taken care of. Social support, caregivers availability and discharge planning. So if caregiver is available, they have just traveled from abroad and they are going to go post surgery, that should not be the thing. There has to be a caregiver who will be there with the patient and who will be able to take care of the patient when patient is discharged at home. That is also needed to be seen in the pre-op assessment itself. So perioperative neurocognitive disorder or post-op cognitive disorder, which we see mostly, it is an objective major decline in the cognitive function that persists beyond the period expected for the normal recovery from the effect of anesthesia and surgery. So it is an objective measure. So we have to have something pre-op only measure, so we can compare with that. So where comes the this mini-COG test? Okay, so something, and that will objectively tell us this patient had declined by some certain point, so needs to be taken care of. The prevalence of dementia, why we are looking at this point? Because prevalence of dementia, even unanesthesized patient, is being 5 to 8% individual more than 65 years of age. So all this will lead to the increased morbidity. The pulmonary hygiene cannot be maintained, ambulation is decreased, and all this can increase morbidity like DVT, pneumonia, or stroke risk. All this increases. Because of that, we have to pre-operatively only assess this cognitive disorder risk. So it can be, it has a big spectrum of the neurocognitive disorder. It can come from underlying patient already has prior to surgery some disorder, or immediate post-operative, that could be delirium or delayed neurocognitive disease, which delirium can last for a few hours to 7 days, and neurocognitive delayed recovery can last up to 30 days. And beyond that, that will be post-operative neurocognitive disorder, it will be called. And then beyond a year, also there have been seen to be having a neurocognitive disorders in this patient. So we have to be very careful in assessing this patient. So as per the American Society of Anesthetists Brain Health Initiative guideline, they suggest the baseline cognitive cognition should be valid in all the patients who are more than 65 years of age, and particularly for those who are already having a pre-existing cognitive impairment or who are at the high risk. So we have to undergo for more than 65 years of age. So this older patient should be informed, and they should be informed, the patient and the relative, of post-operative exacerbation of this cognitive impairment, and if it is already present, or it could be there immediate post-operatively, and mostly it is temporary and patient comes back to the normal thing, but we have to inform this to the patient. For this, we can do a screening test which is called as mini-COG. So what do we do in mini-COG? We give 3 random words to the patient to remember. Like if I say picnic, basket, or gas cylinder, something like this, 3. And after some time, tell the patient to repeat it. Or ask the patient to draw a clock by the time and tell the patient, like, I want time to be 12:30 in this or 12:20. Patient can draw the clock. Circle should not be an exact circle, but you can draw a clock and put the hand at the 12 and at 6. That means 12:30. Patient can draw properly. That means, and after that, you ask again patient to repeat these 3 words which you have asked prior. If patient can recall all 3 words, that you don't suspect that patient to be dementia. If patient cannot recall any word, may be suspected dementia. If out of 3 patient can recall 1 or 2 and patient has drawn the clock properly, then you do not suspect. But if it is not there, then you may suspect the patient to be dementia, and we have to go for further evaluation in this patient for the cognitive disability. So to prevent this, what we can do? One thing, education of the healthcare professional is very important. We have to know that there is something called mini COG test, which we have to do and know our high-risk patients. Okay, we have to follow the ERAs, early mobilization, feeding of this patient, okay, daily physical activity, keeping the caregiver with the patient if possible, that who is known to the patient, pain management, appropriate medication to the patient. Appropriate medication, I will say along with that, like opioids, benzodiazepine. These are the drugs can push the patient into postoperative delirium, which we have to try to decrease the use. Adequate oxygenation and prevent constipation. This all comes under preventive for the cognitive dysfunction. Next is we have to assess for the anemia. So nutritional assessment, anemia is very important. Anemia can be because of the elderly patient iron deficiency, chronic disease of inflammation, malnutrition, or bone marrow dysfunction. And if we optimize we screen the patient, optimize the patient of anemia preoperatively, so that they can manage the patient blood management also, and we increase the good outcome of this patient. So in a study which has been published recently, which showed that they saw the association between the pre-op anemia and cognitive function in the large cohort of the older patient undergoing elective surgery. This is a cohort of 8,640 patients with age group of frequently associated with the greater cognitive vulnerability, high ASA physical status, and increased frailty score. And pre-operative anemia is an independent predictor without a frailty score and the cognitive vulnerability. It is an independent predictor for worse post-operative outcome. With the longer ICU stay and longer hospital stay, non-home discharge, and high 1-year mortality. 1-year mortality, they have seen it is increased 2.7 fold to 3.6 fold higher in the patient, 2.7 fold higher in the patient with the grade of 1 anemia, and 3.6 fold higher in the moderate to severe grade of anemia, less than 8. So next is the assessment of frailty. So frailty, it is a widely recognized as the clinical syndrome reflecting the age-related vulnerability and diminished physiological reserve, resulting in the increased risk of an adverse health outcome when exposed to the stresses such as surgery. So frailty predicts the post-operative mortality, morbidity, which will include morbidity will include the delirium, cognitive impairment, postmortem pulmonary complications, longer hospital stay, or longer functional decline. So frailty is a very important point we have to see. Like maybe the different patients with the different illnesses, the frailty index at the same age, at 60 years or 65 years, may be different for the patient. So we have to see that, and from that individualize the treatment. So in the meta-analysis which was published in 2022 and analgesia, it showed the association between the frail scale and the post-operative complication in older patient. It was in the 18 studies where 4,479 patients was been screened, and that mortality was higher for the frail patient compared to non-frail patient at 30 days and even at the 6 months. So it gives you the long-term mortality as well, which was with the odds ratio of 6.62 and odds ratio 3.11, which was quite high. Also the morbidity, that is post-operative complication, including delirium or a postoperative pulmonary complication, DVT, it was also higher, and postoperative delirium also was higher. So frailty comes with the increased mortality and morbidity. Also, there was a study which was seen in 992 older patients, which also showed a higher mortality, 1 year mortality, four-fold increase in the mortality in the frail patients. So frailty assessment can be done by multiple things, but let's go to the one marker, that is surrogate marker, which we use is time tug marker, which is more than 20. If it is 20 seconds patient takes to get up from the chair, walk till the 3 meter and go back, then that tells you have to go for the testing for the patient. And these are the other scores which can apply as well. So frail score, which is the easy one to apply, which can apply in our OPD itself, is that fatigue. If you are fatigued, you have to ask the patient. If most of the time it says yes, it goes as a 1 point. Less times or none, then it will go as 0. Then resistance, the difficulty in walking the stairs, difficulty in walking 1 block, more than 5 illnesses are there, or if the patient has lost more than 5 kg weight in last year. If anything of this comes as a yes, then it will score as a 1 point. And then when you do the scoring, if 0 score, that means patient doesn't have frailty, 0, robust patient. If it is 1 to 2, pre-frail, then we have to start either deconditioning the patient. If there is we have to start a physiotherapy for the patient, nutritional assessment and nutritional support to the patient. If frail 3 to 5, that is associated with a higher mortality and morbidity, which needs to be explained to the patient. We try to optimize it. Okay, so in the general population, in the cohort community living adult patient, where the 1 year mortality after major surgery among the community living older US adults was seen, the 1 year mortality was seen to be 13.4% in the elderly age group. Okay, and non-elective surgery, emergency surgery, the risk increases 3 times, that is 22.3 versus 7.4%. Frailty increases the mortality risk. If you can see here, 27.8% in frail, whereas 6% in non-frail patient, elderly frail. Also, dementia, it is also seen that 32.7% higher mortality was seen in this patient compared to those without dementia. So, all this the study underscores the prognostic value of geriatric condition, that is frailty, dementia, in perioperative assessment and shared decision making for the older surgical patient. Next comes the anesthesia. I have skipped the pre-medication. So we have to be very careful about the pre-medication in this patient, which they are more exposed to the hypoxia, airway obstruction. So we have to be very careful with the pre-medication. Also, benzodiazepine, when we are using, they can push the patient to the neurocognitive dysfunction post-operative. We have to be careful with that. Investigation, as per the guidelines, which are most of the US guidelines, they say if the patients are being followed up yearly or something, so they have the investigation. But in our situation, like India, the patients must have not come for 5-10 years prior to any medical center, and now they have come, then we have to ask for the ECG, electrolytes, because hyponatremia, hyperkalemia is more, RFTs, LFTs. These are the basic things. And CBC for any infection, if there is any, which is not picked up. That's anemia we have to see for. All this, so basic blood investigation and ECG. I will not say echo every time, but at least ECG is a must for all this patient. So if monitor anesthesia care, next is the monitor anesthesia care we have to go ahead with. So most susceptible for developing the airway obstruction, hypoxia, hypercarbia, and aspiration for this patient because of the reduced pharyngeal sensitivity. So we have to be very careful of the doses of how much sedative we are administrative, and analgesic medication, whatever we are giving. If opioid based, we are thinking of a medication. Well, this patient should be having all the AC monitors. Even with the Mac, you get the nasal prongs which have the ETCO2 attached along with it inbuilt. That should be used for this patient. At least we'll come to know the patient is not hypercapnic, a patient is not having a depressed respiration in this patient. That will help us to know the thing. So, and if patient is not cooperative, cognitive dysfunction is there, require deeper sedation, better to go ahead with the general anesthesia for this patient instead of just supplementing the and increase, or if it is taking longer time, instead of just supplementing the opioids, which can be opioid or propofol, any other induction drug, which can be a cumulative dose, and then patient will take a prolonged time to awaken. Next comes the intraoperative management. We have to be very careful of selection of the and dosing of the anesthetic agent. Positioning, which I have already told you about. We have to be positioning, pressure points need to be taken care of, no fractures should be there, no points should be taken care of. Hypothermia is very common in elderly patients, so we have to take care of the OT temperature. We have to cover the patient well. We have to use the IV warmer, as well as we have to use the bear hugger or something, or the surface warmer. Hemodynamic management, which is very common in the elderly age, which we have seen. We need to be careful with our drug dosing, and if there is a decrease in blood pressure, we should not wait for it. We should act on it immediately. And monitoring. Along with all the AC monitor, if you are giving muscle relaxant, neuromuscular monitoring is a must for this patient. That will help us to know the repeat dose when to give, and also help us to know for the will help in reducing the residual effect of the neuromuscular block. BIS monitoring, yes, that can help us to minimize our inhalational and the IV anesthetic agent to maintain the patient between the adequate depth of anesthesia. So pharmacology, I'll just go in brief. There is a need to decrease the multiple drugs like induction agents like thiopentane and propofol. There is the increase of volume of distribution initial, which I have already spoken to you, because of the decreased in the central compartment. When initial dose you give, that will have a that will be increased plasma concentration. So we have to reduce the initial dosing. The clearance also is decreased, especially with the propofol. Because of that, we have to decrease the dosing, even the induction dose, by 30 to 40%, and the maintenance dose as well. Etomidate, it decreases the initial volume of distribution, so it is desirable to decrease the for the hemodynamic. It maintains the hemodynamic stability, but we have to decrease at least by 50% dose reduction is required. Opioids like fentanyl and morphine, there is a decreased clearance, reduced renal clearance of the metabolites as well. Because of that, we have to be and it increases the risk of postoperative respiratory depression and postoperative delirium. Because of that, we have to be very specific with how much dose we use for the opioids. It should be decreased dose. Muscle relaxant, because of hepatic and renal decline, we prefer to there could be a residual muscle blockade postoperatively. So either you use a neuromuscular blockade to know the monitoring to know what is the depth of your neuromuscular blockade, or use the Sugama test, or use atraquinone or cisatraquinone, which will go for the Hoffman elimination. So liver and kidney will be out of your league. Next comes the inhalational agent. Because the VQ mismatch affects the uptake and also reduces the cardiac output, will cause the speed of onset to be increased. So this, because of that, MAC requirement decreases in case of the inhalational agent. It decreases up to 6% per decade after the age of 40. So you have to also have a gas monitoring when you're. It's ideally to have a gas monitoring. If not there, you have to see to that you maintain the depth well. Next comes the question, we have to go for regional or general anesthesia. So there are multiple advantages of regional anesthesia. It causes the opioid sparing effect, provides the adequate analgesia both intraoperative, postoperatively, and it will add up to your multimodal analgesia technique. It reduces the risk of postoperative complications like pneumonia, DVT, improves the mobility of the patient, reduces the cost, and also causes opioid-free anesthesia, which is beneficial to impact the postoperative delirium. Okay, but there have been studies, especially there is a study which was RCT, which was in 2021 in 1,600 patients of more than 50 years, where the mean age was 77 years, who had undergone a hip surgery. In that, when they give general anesthesia or spinal anesthesia, the mortality and recovery of ambulation at 60 days was similar in both the patient. And the same study, when they did the follow-up of the same patient, Then they got a long-term outcome over the first year after the surgery, where the mortality and the recovery of the independence in ambulation, they were same in both the general anesthesia as well as the spinal anesthesia. So it says that if you have to go ahead with general anesthesia, there is no harm. But there are multiple studies which have shown that neuroaxial and regional is better in reducing the pulmonary complication, postoperative delirium, and postoperative requirement of ventilation, especially in COPD patient. Meta-analysis of 29 studies with 10,000 plus patients has shown that significant reduction in the length of stay, hospital stay in the patient with the neuroaxial block. But also there was few studies which have shown that the length, those are the retrospective study, so I will not give it a very much. Length of ICU stay or recovery stay is lower in the patient with the general anesthesia. So it shows the both risk benefit. But as per the thing comes, we should try to go ahead with the regional anesthesia as much as possible if patient is cooperative and patient understand the risk benefit, and then or it can be multimodal. Then comes the enhanced recovery after surgery protocol, which should focuses on the pre-op carbohydrate loading, physiotherapy, and nutritional support pre-operatively as well. Fluid should be goal-directed fluid therapy is advisable because this diastolic dysfunction and there is a hypertrophic left ventricle. This patient with the less fluid will cause a decrease in preload, and little extra fluid will cause the pulmonary edema in this patient. So we have to be very careful with the fluid. Then also the blood management should be little restrictive, with the HB can be kept up to the 8. Postoperative early ambulation and feeding is must for the ERAs. So postoperative concern that comes along with the same thing. One is the pain management. Either if we have a regional, that is the best. If the catheters are present, we can go ahead with the regional supplementation, but we have to see to that the doses are adequately given. Then if not, then patient should go ahead, we can go ahead with the multimodal. NSAID you have to be careful because of the kidney dysfunction. Paracetamol can be given in the lower doses. Along with that, opioids, we have to be careful of respiratory depression in this patient and also for the postoperative cognitive dysfunction. But PCA, if patient can understand and take, patient control analgesia is the best for this patient. Second is the postoperative pulmonary complication. The rate is high, as I've already told you the reasons for. Because of that, we have to encourage coughing, encourage physiotherapy, encourage spirometry in this patient, and we should start pre-operatively and continue post-operatively so that we can decrease the post-operative complications in this patient. For cognitive dysfunction, if we have done the Minicog test pre-operatively, we can explain the patient postoperatively, you can have this, and we can avoid certain things to avoid the postoperative cognitive dysfunction. ERAS has to be followed for the rapid recovery of the patient. Shared decision making, yes, it is, which is very important for the elderly patient. One thing is 3-step modalities. One thing, you have to inform the patient and the relative, the options, risk of postoperative cognitive dysfunction and or postoperative pulmonary complication and benefit. Then you have to reflect the patient, consider their personal values and goals. If and fear, everything, if patient is saying that I don't want to be dependent and I don't want to get the surgery, you have to respect that. And communication, you have to patient conveys this goes to the provider and reach for a personal decision. We have to be able to have a one-to-one conversation with the patient and the caregiver, like what is best for the patient, that decision should be taken. And recent update, I will say in the geriatric, one is on monitoring. Dysmonitoring and cerebral oximetry is coming more in the more and more in the light to decrease the postoperative cognitive dysfunction in this patient, to maintain the good depth of anesthesia and decrease blood supply to the brain, and that will help in better cognition postoperatively. Individualized plan is needed, precision with the medicines and pharmacological test, pharmacogenetic testing, and ERAS, that is the minimal fasting and prehabilitation, is must for all this patient, and that is coming more and more into the picture. So elderly patient require cautious care and support perioperative period. The multiple comorbidities condition, decreased functional status, decreased respiratory reserve, frailty, cognitive decline, limitation in mobility, and polypharmacy place them into greater risk than the normal adult. So in geriatric patient, anesthesia is not about the age, it is about the physiology, frailty, and function. Thank you. Free to take any questions?
Madam, it is truly a rich and enriching lecture.
Thank you.
It was a very detailed, in detail lecture, I think.
I know. I was told it is for the resident as well, so I
Yeah,
thought I'll
Yeah,
try
yeah.
to
And they
emphasize
all
on
are
the-
attending and they must have really benefited from your lecture. And the whole one geriatric topic has already been covered now. I can state that it's been covered now.
Thank you, thank you.
Thank you so much. It was such a detailed and very good lecture.
Thank you, ma'am.
Over to you, Samrat. Are you there?
Yeah. Thank you, ma'am. Thank you, Bindya, ma'am. It was an excellent lecture, very comprehensive.
Dr. Samrat.
I'm sure all our audience and the postgraduate students and everyone who is there will definitely benefit from it. Ma'am, we could take a few questions. Like if there are any questions, you can ask. We can take questions regarding pediatric as well as geriatric. So if any questions, you can just unmute yourself and ask directly. So few of the questions sir has already answered on the chat box, I guess. So one question from the user was, can we give oral atropine in pre-op period, as many times ketamine is used for small cases and secretions? So I think sir has already answered this. Vinit sir?
Yes, it can be used. It is not contraindicated. Mostly these days, it's not given. Many a times, what happens is the children become very flushed actually, and then sometimes they also sleep quite a lot during the pre-op as well as the post-operative period. Having said that, a lot of surgeons, ENT surgeons, prefer it for adenotonsillectomies, especially the old school ones. It actually gives a very good oral mucosal coverage. The dryness which it gives, but then it can be bothersome in the post-operative period. If you're using ketamine, midazolam, sometimes glyco, but again, I have not seen any problems with 1 to 2 mg per kg of dose of ketamine at all. If you're using as an oral pre-medication, a dose of 5 mg per kg, oral atropine can be added to it. Definitely, why not? As I said, midazolam is a better option, even in inexperienced or less experienced hands. It is a wonderful drug with least complication profile. It's a very safe drug.
Absolutely. One more question, sir, to you. Especially when we are doing pediatric cases, especially non-cardiac cases, pediatric cases, what would be our priority? Would it be hemodynamics or would it be the respiratory drive of the patients that's ongoing?
I didn't get your question. Are you speaking about any specific case per se? Like
Yeah,
which
a specific
non-cardiac
case
case
is-
are you?
Overall, this is for the benefit of our postgraduate students. If
Okay.
we are doing a pediatric case under general anesthesia, like
Okay.
what would you like to give more importance to? Whether it would be the hemodynamics, that is the blood pressure monitoring, or whether it would be the respiratory efforts and the respiratory components that are ongoing.
They will play a role in a different aspect, in the sense that intraoperatively, if I'm knocking off the patient and I'm giving itracurium, definitely I'll ventilate the patient. Hemodynamics will definitely play a role with respect to maintenance of the surgical field. And then while the patient is getting up or coming out of anesthesia, then respiratory efforts will definitely matter. So it's a very case specific thing which you're asking. If you can give me an example, I'll be able to answer it better, maybe. I hope this answers your question. I'm not sure. Like, I didn't get your question at the first place with respect to a specific case.
Yeah. So basically, what I wanted to, ask you or just get your inputs from was that the respiratory depression part or the respiratory arrest or hypoxia is basically one of the major problems that we most often, because of which the pediatric patients develop into complications or the post-operative things. So that is one part that we have to monitor. Completely throughout. And hemodynamics, they do play an important part, but looking at the respiratory parameters is also as important as compared to the.
So frankly speaking, whenever a patient lands up into hypoxia, there will always be hemodynamic perturbations. So each and everything is important. Basically, like when I was a fellow or I was studying, I was being taught that spasms are caused. If a patient is on table who doesn't have a very active pneumonia, a laryngospasm is always iatrogenic. It's the way you induce a patient is what is important. Again, as I said, if there is a laryngospasm, there will be hemodynamic perturbations. Of course, hypoxia stands like, if you ask me two quintessential things in pediatric anesthesia, one is a secure airway, another is a good flowing IV. Even if I don't have a central line, I'm okay with one good flowing IV and a secure airway. Hence my slide of endotracheal intubations, especially for people who are kind of novice to the field. If you don't have to kind of think twice to intubate a patient. If you feel that's the safest way to do it with endotracheal intubation. There is no problem of using a tube instead of a mask or an LMA. So hypoxia prevention definitely kind of tops the chart.
Absolutely. Thank you, sir.
One question is whether the spasm has reduced, rate of spasm is reduced because of the use of propofol.
Definitely, ma'am. It reduces the reflexes altogether. And even in less experienced hands, even if you think that the patient is kind of landing into a spasm, just give 1 to 2 mg per kg of propofol and establish good mask ventilation. It will avoid a lot of problems.
You said some laryngospasm, fossa,
The notch.
that is behind the mastoid.
Yes, just below the ear, behind the mastoid. That is one way of relieving the spasm.
But
It's
is it
basically a
really,
painful.
does it really act? Means I have read it, but I've never
So
used
the best way to tackle is propofol, as you rightly said. Deepen the plane of anesthesia. I say propofol because choline nowadays is almost obsolete, and using a relaxant again would mean there might be a situation where we can't ventilate the patient. Propofol will reduce the airway reflexes. It will deepen the patient enough so as to mask ventilate the patient and get a saturation which is a good saturation or 100% saturation. So propofol does the deal.
One more question from my side is when you say intranasal midazolam or any drug you want to give, you use a nebulizer or you use a spray?
So in our setup, we don't use sprays. Now, sprays are usually used by neurologists. The dosages which is used to break epilepsy or a seizure is the dosage which is available in the spray. What we do is we can take some Loxicard. For example, it's a 10 kg child, 0.3 mg per kg, that is 3 mg of midazolam. It comes in ampules, 1 ml is 5 mg. So you can aspirate 3 mg, take some Loxicard along with it, and just put it gently, drop by drop, in the nose of the child. It's a bit irritating, but it acts wonders.
But then he will tend to swallow it.
They will eventually, yes, they will eventually swallow it.
Any more questions?
No more questions, I think.
Yeah. Just one more question to Dr. Bindya, ma'am. So, ma'am, excellent talk. You included everything in your presentation, especially I like the frailty part that you have covered in your talk. So, on a day-to-day basis, do you do the frailty assessment for all the geriatric patients?
We have in our institute, we have a geriatric clinic. So we'll end up sending them to, if more than 65, we'll end up sending them to the geriatric clinic. That has been started, where they get assessed and they get rehabilitated.
Okay, because recently a lot of stress has been given on different frailty score, but
I think that is a must, and it is an easy way to do the thing, right? Either the frail test can be used or the tuck test, which we just have to make the patient, like when you're seeing them in the pre-op clinic, if you just draw a line from where the patient is to the pyramid and just make them walk, that will give you that we need to assess them or not. That becomes a very easy thing and can be done easily. Even the mini cog, it's a very easy thing, can be done in the pre-op assessment itself and gives us a better idea.
So rather than just defining the age by numbers, I feel it's better to use these different scales and then guide the patients in the intraoperative and the postoperative period.
Definitely. So someone who is obese, like not doing exercise regularly, not even doing a normal walking per day. That patient and the person who's running a marathon, Definitely at 65 also they'll have a different frailty index. So you have to take them as an individual and go ahead with them.
Absolutely, because I had a case, we had operated a 93-year-old patient for coronary artery bypass grafting, and to my amazement, just this was done a couple of years back. She did absolutely well in the post-operative period. So that was just because she had a good score, she had a good frailty score, we had assessed her, and that is the way I think we should go about it. Thank you, ma'am.
Definitely.
Excellent talk.
Thank you.
With the permission of moderators, any other questions, or should we, proceed further for vote of thanks?
We can proceed, I think.
Yes. Before that, Dr. Rajesh Tagadpalle sir was here some time back during the talk was going on. Actually, I wanted to invite him also to speak a few words, but I don't know. I can't see him right now. I think he has left currently. So maybe in the next webinar or somewhere we will like to have him and guide us further. Anyways, coming to the end of this session, let me give the vote of thanks to all the respected dignitaries, esteemed speakers, moderators, seniors, and my dear colleagues. As we come to the end of this wonderful academic evening, it is my proud privilege to propose the vote of thanks. On behalf of Karad ISA, I express my heartfelt gratitude to SAMS Maharashtra for their valuable collaboration and constant support. Their guidance and encouragement have truly strengthened us and strengthened this initiative and made today's program possible. I extend my sincere thanks to our respected dignitaries, respected President Sir, respected Secretary Ma'am of SAMS Maharashtra, and all the office bearers of SAMS, the GC members of SAMS, and the national members, and all our Karad ISA members, as well as all the audience for their inspiring words and their blessings. Your presence has added a great meaning and motivation to this event. Special word of gratitude to our eminent speakers, Dr. Vinit Bedekar sir and Dr. Bindya Saunke ma'am, for sharing their knowledge, experience, and precious time with us. Your sessions were not only academically enriching, but also practically relevant, and we are truly grateful for your teaching. I would also like to thank our moderators, Dr. Nasima Kanse ma'am and Dr. Jeevan Patil sir, and Dr. Shraddha ma'am also for guiding us and having this conducting this CME and this workshop, this online webinar in a very smooth way. And at the end, I would also like to thank all my postgraduate students and all the people who have attended this webinar. And as this is the first webinar of Karad ISA in this year during my tenure, I am deeply touched by the love, encouragement, and support that we have received. And as a team from Karad ISA, we promise to continue working with the same dedication and sincerity for the rest of the period. With this, once again, thank you all from the bottom of my heart, and I look forward to many more such meaningful and academic interactions. Thank you, and have a wonderful evening.
Thank you so
Thank
much.
you.
Thanks for
Thank
the
you very
award.
much.
Thank you for the invite.
Vinit sir, and thank you, Bindya madam. Excellent lectures.
Thank you, ma'am.
Thank you, madam.
Thank you. Thank you.
Thank you, everyone.
Thank you, everyone. Thank you, Samrat.
Thank you,
Thank
Samrat.
you,
Jeevan sir.
Excellent meeting webinar.
Thank you.
Start and Dr.
Thank you
Jeevan.
all.
Excellent webinar without any interruptions or any chaos. Many a times, even you have to in between the net goes and all those, but it was very smooth, absolutely smooth webinar.
Absolutely. And congratulations to everyone, ma'am, especially all our Karad ISA members also. And with the breathtaking efforts from Dr. Shraddha ma'am, yourself, and even President sir and everyone, we have procured the dantrolene. So it's absolutely an achievement and a feather in the cap of Karad ISA. So I'm really proud to be a member of Karad ISA, and I just have
अरे
one word to say: long live Karad ISA.
लॉन्ग लिव कराडायस
It
ते
is
ठेवायला जागा शोधा मेरे को टेंशन आ रहा है मेरे पास रखो
नाही आपण हे पण
Ma'am,
it is also because
that will discuss on our
मला झोप लागणार नाही
meeting, rest of the meetings.
no, we should thank even all the ISA members who consented to go procure dantrolene also. They gave their permission and their consent to get dantrolene. So we should
Absolutely.
get a vote of thanks to even all the ISA members who consented for it. So we could get the injection.
Absolutely.